Okay. Good evening. My name is Saraswathi Vedam, and I'm a professor of midwifery at the University of British Columbia, which is located on the traditional and unceded territories of the Musqueam, Tsleil-Waututh, and Squamish nations. I'm pleased to be here with you today. We've been spending quite a few weeks discussing the complex concepts of measurement of respectful maternity care, and in particular, whether it's possible, whether it's feasible to create global, national, and regional indicators of quality of care that are based on experience of care. So today I'd like to spend a little time telling you about what my lab has done to create a core set of indicators that are reliable measures that are based on service users' concepts of what quality care means. I'm just going to share my screen with you. Okay. I believe you'll see my slide now. There you go. Okay. So when we set out to create a core set of indicators, we of course always have to think about reliability and validity and measure and whether or not it's feasible within the systems that we have already. So I have no conflicts to declare. My research and my lab are certainly supported by a number of generous donors and funders. And the work that I do at the lab with my colleagues is focused on measurement of respectful maternity care, and how a birthplace, provider, person-centered decision-making, all the components of experience of care that relate to high quality care. We work with our community so that the right information reaches the right people in the right way. We prioritize indicators that are designed by service users when measuring experience of respect and disrespect, and mistreatment. And we strive to ensure that those stories that when we work with our service users, that they are able to help us prioritize measurement of concepts that actually will make a difference, that actually are actionable. And so I think that that approach is particularly relevant to what we are trying to do on a global level. In our discussions, I heard a lot about the difficulty of measuring complex things like autonomy, whether or not those types of metrics were already being collected. How would you provide accountability for that, and at what level should we be? Should we be looking at health systems? Should we be looking at individual providers? I think that we didn't always have consensus, so I'm going to give you my perspective on that. This work is based on participatory action studies that we did in BC, in the US, among communities of color, people who planned to deliver in the community. We're currently doing a national study. In fact, it launches tomorrow. It's called the Respect Study, and it is a national study looking at care and experience of care across a number of marginalized communities. We're also involved in a study, developing a study around care for LGBTQ two-spirited families. All of our research is been moving towards a community-based participatory process where we start by creating a multi-stakeholder team. They help us secure the funding. They co-create the instruments and the measures that we use. They help us with recruitment of participants, and then also identifying the key messages and what to do with the data that we have. And so they're very engaged, our service users and partners and clinicians, in making sure that we're measuring in a way and measuring items that are truly relevant to the delivery of care. in the context of the RESPECT study, we put together a multidisciplinary, multi-stakeholder team. We actually have over 60 people who are regularly involved in our leadership team. They are service providers and service users. They are NGO leaders and community-based organizations that serve disadvantaged populations. We have representatives from professional associations, as well as researchers from a number of different disciplines: public health, midwifery, obstetrics, sociology, psychology, anthropology, and indigenous health. In addition, we've put together a steering council of just service users. And in fact, they are leading the entire, every decision we make has to be passed through the steering council of service users. And those service users come from all 10 provinces and are have multiple identities that represent the types of populations that we are trying to understand the experience around. The goals of the RESPECT study were to develop a valid and reliable person-centered survey that measures quality of care. And of course, quality of care, we're beginning to broaden our understanding of that. And according to the WHO criteria for high quality care in health facilities, we're also talking about respectful maternity care and things like that are delineated now in the RMC charter, which we discussed just last week. So we are looking to describe the proportion of women reporting respectful maternity care in Canada and how those experiences are associated with models of care, where they live, what their personal characteristics are, do they have comorbid conditions or access to services. And in particular, we want to focus our data collection on those most marginalized communities, because we know when we get it right for those communities, we get it right for everybody. So we are particularly trying to recruit people who come from communities of color, people with disabilities, people who are Indigenous, immigrants and refugees, from non-gender conforming and identities who are LGBTQ, people who have housing instability or other types of life challenges. When we convened our multi-stakeholder time, and we talked a lot about what were the best indicators of respectful maternity care. We know that this has been studied broadly in LMICs. We are interested in we were interested because we were looking at communities that come from many different countries. We wanted to have measures that were relevant across contexts, not just for care, and not just for a high resource country, but for the lived realities of these service users. So the team decided to do an environmental scan, first looking very broadly across the world about how people were measuring this and were there validated indicators. We knew that Borean and colleagues had described these domains of mistreatment. We started there, and then we decided to do a Delphi process, which I'm going to tell you a little bit more about, to seek consensus in the context of high and middle resource countries about how you measure these complex concepts. So we started, as I said, with item generation. So we did a wide literature review. That literature review included our previous studies and measures that we've used and developed new novel ways to look at concepts, scales that we had developed. We also did citation chaining. We looked at scoping reviews and systematic reviews of respectful maternity care and also patient experience. And after removing duplicates, actually we had a master's student who did a parallel, very formal process, and we were happy to see that both of us came up with the same set of 47 articles. We then limited the studies to patients, to those that had patient input in the design of the measures. That brought us to a set of 300 items drawn from about 21 different studies and reports. We were able to reduce that to 201 items. We first sorted it by the Borean themes for mistreatment. We removed similarly worded items, prioritized the items with ambiguous language, and then phrase those items in the first person, because that's what the service users wanted to do. And then we wanted to make sure that we selected items that were measurable in a quantitative survey. So that was our process first. Now, once we had this big set, we knew that was too many items to have any one person answer. So we had to do a process of what were the most important domains to measure and what were the best items in each of those domains. So as I said, we engaged in this Delphi process. We first took our environmental scan and sorted all of the items, the 200 items that we had across the foreign themes. And then we realized that we had both deductive themes and inductive themes. So we reworded the domains into sets of items that were talking about things like physical mistreatment or verbal mistreatment or information and consent or privacy. And then we found that there were also items that were relevant to people's concepts of respect, which had to do with the patient reactions or nonverbal communication or health systems conditions and constraints. And those could be physical or they could be human resources. Our process for the Delphi process, for those of you who are not familiar with that, it is a method of consultation over multiple rounds to describe new concepts and so these respectful maternity care is not so new anymore, but there isn't a lot of consensus about how we measure these things. Many different countries and contexts are looking at different items, and no one knows what is the full set. So we said, let's put together a global Delphi panel. We used best practice by having a heterogeneous representation. So again, researchers, clinicians, doulas, consumers, NGO leaders. And we had about 34 experts who engaged over multiple rounds with global representation. And we used an online tool so that they could provide their input in an anonymous way. In round one, we asked them to we presented each one of those items to them and asked them to quantitatively rate them for importance, relevance, and clarity, to suggest any missing topics and suggest revisions for items that were unclear. In Delphi round one, here's a screenshot of what it looked like. So we'd present them an item, and then they would actually choose one of those rating tools, those rates. They could also give us summary comments about whether or not we should leave the item as it is, discard, or revise it. So this is an example of round one, where we had the health worker or other staff member made negative comments about my physical appearance. The health worker or other staff member made negative comments about my baby's physical appearance. I was shouted at or screamed at. I was mocked. I was insulted. Providers threatened to withhold treatment. So it went from, again, across many domains. We grouped them all under each of these themes. So these were all verbal abuse ones. We had ones also around cultural safety, others I'm going to show them to you in a moment. We did this quantitative assessment, looked at the degree of agreement for each of these items. And in fact, there was a lot of consensus around, everybody felt all of it was important. We did exclude 10 items that didn't reach that content validated index cutoff. Then the team reviews the items, merged and reworded and retained items that were unique and not duplicative. And we wanted to be sure, our steering council members said, we can't just look at disrespect and mistreatment, we also have to look at respect. So we made sure we retained those. And then we went back to the panel and asked them to prioritize those, because we knew that 200 items was going to be too much. And so we sorted them into 10 domains and provided them a tool across these 17 domains. So across these 17 domains of respect, disrespect, and mistreatment, and you can see how many items we had in each of these domains. We then asked them to drag and drop the priority. Which ones did they think were most important? If they would pick their top 5, or they could actually, however many there were in the domain, they could rank order them. And then we also looked at the degree of agreement as far as the rank ordering. And that helped us now start to understand what was most, we asked them to think about the communities that we were trying to address in Canada across all of those populations, and also think about the context of care in Canada. So they were able to give us some qualitative rationale around why they prioritized in a certain way and what they wanted, what their perspective were. We took that into account when we looked at it. They said that sometimes they were really reflective about whether or not their actual clinical practice would make them behave differently in an acute situation versus not. And they wanted to have to say that the gold standard is to look at care when there isn't an urgent situation, because that should be the gold standard for how we behave all the time. So not all of it was about provider interaction, but that was just sort of some of the kind of information. You know, when we co-create our RMC measurement like this, their strengths are that what we did was we did the global scan, we took validated items, we looked at person-centered and women design items, we had a heterogeneous panel, we did formal quantitative rating, we considered qualitative comments and feasibility, and the roundness of what we were measuring. Interestingly, though, even having gone through all this, we found that the panel as a whole prioritized items that they thought. But when we went back to our global steering council, they said, actually, the agreement did not prioritize something like forced sterilization in Canada, because the bulk of the panel felt maybe that isn't really that relevant here. But the service users who came from these lived realities said, no, you cannot take that out. And so we actually put back in or reprioritized items that were part of the lived reality of the most marginalized when we put together. So we put all of this together in a registry format. It's going to be open source and available to you. You can see that we have all of the domains. You can click on any one of these domains. It will bring up the domain and the items that measure within those domains, that globally there's agreement about the right ways to phrase it and measure it. We have them in many different domains. If you then click on any one of these items, it will show you what the source of the original items and how we adapted it for the RESPECT study. So we're trying to make this so that we all start to measure things in the same way. We're about to launch our RESPECT study. It will start tomorrow. It actually is launching tomorrow. And just, I'm going to close soon, but I want to give you a sense of what we can do when we measure things in this way, with reliable, valid measures that are focused and located in patient experience. As I said, we had this survey construction together. We measured mistreatment. When we found in the previous study that 1 out of 6 people in the US experienced mistreatment, and when we analyzed that mistreatment by communities of color, we found it was 2 out of 6, which is exactly the same rate that we have in LMICs. When we looked at mode of birth, we could, by measuring that, we could see that it was connected to mode of birth. We could see it was connected to mortality, and that in fact delays in response to clinical warning signs were one of the predictors of mortality. We've also created some scales to measure complex concepts like autonomy. We had a long discussion about autonomy recently, and we have a scale called Melville's Autonomy and Decision Making, which gives you a score for the level of autonomy. And you can use those scores then as an outcome measure. And I won't go through because all the things, but I just want to make the point that you can have a quantitative measure of something like autonomy, and then you can connect it to sociodemographics. You can connect it to the type of provider they have, whether or not they are low socioeconomic status, whether or not they have complications. You can also connect it to place of birth, which of course is so important today in the time of COVID. We have a similar scale on RESPECT. These are all embedded in this registry. And that can give you a quantitative measure of overall respect that people have. So, and that can be disaggregated by community, by socioeconomic status, and give us an overall sense of what quality of care is. Thanks very much. You can access the registry and these items by going to our website.